Hello and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Sharif Mursalin. Today's podcast features Dr. David Miller, a medical oncologist and dermatologist at Mass General Brigham Cancer Institute and Harvard Medical School, and Dr. Vishal Patel, cutaneous oncologist and Mohs surgeon at the George Washington Cancer Center. They'll be sharing their insights on translating discoveries into clinical practice to advance the care of patients with cutaneous squamous cell carcinoma. For more information on our presenters, along with a link to the full educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
Hello, everyone. I'm Dr. David Miller, and I'm joined today by my colleague and friend, Dr. Vishal Patel. Vishal, as always, it is great to be here with you.
Thanks, David. It's a pleasure to be here with you, especially good colleague, good friend, and expert in everything melanoma, non-melanoma, skin cancer. Before we talk about what's new in CSCCs, it's important to remember what hasn't changed. And cutaneous squamous cell carcinoma remains incredibly common, and the vast majority of cases that we see are cured with surgery alone. But there are a small subset that develop locally advanced or metastatic disease. And for those patients, which account for the disproportionate share of mortality, it can be challenging. And that's what we're going to be talking about today. What's exciting is how fast the field is evolving. For the first time, we now have immunotherapy approved in the adjuvant setting. Cemiplimab for patients at high risk for recurrence after surgery and radiation. And that's really shifting how we think about treatment planning.
Exactly. It's truly a milestone moment for CSCC. We've moved from reactive care, treating recurrence once it happens, to proactive, preventive strategies designed to reduce recurrence and improve surgical outcomes. And throughout today's conversation, we're going to explore that full continuum, how neoadjuvant immunotherapy is helping downstage locally advanced tumors before surgery, how adjuvant PD-1 therapy is changing long-term outcomes for high-risk patients, what the data tell us about biomarkers, where they're useful and where they fall short, and how we can use evidence-based management of immune-related adverse events to help keep patients safely on treatment.
Yeah, it's really exciting, really interesting stuff. We'll also touch on some of the advanced treatment strategies for special populations, older adults, patients with limited life expectancies, patients with significant comorbidities. This is the majority of the types of patients that have cutaneous squamous cell carcinoma, the ones that have the advanced disease. And we need to think about balancing efficacy with tolerability. Plus, we'll look ahead to emerging approaches like intralesional immunotherapy for localized disease, a fascinating option, especially for me as a Mohs surgeon, thinking about how we can expand treatment for patients who can't tolerate systemic therapy, but also not the ones that I want to cut on, not the ones that are good surgical candidates, really increasing our potential armamentarium of treatment options for these patients.
Vishal, it's a lot to cover, from prevention to personalization. But let's start by setting the stage with where we are today in CSCC management and why these new systemic options represent such a meaningful step forward. So with that background, let's shift from prevention to what's happening before surgery, where immunotherapy is being used to make difficult operations less morbid and sometimes even unnecessary. The neoadjuvant setting has quickly become one of the most exciting frontiers in CSCC.
And not just CSCC, I mean, oncology as a whole, but CSCC is truly a great example of this innovative approach. And that story of that innovative approach really begins with early institutional experience at MD Anderson, a pilot study by Ferro and colleagues where patients with resectable but locally advanced CSCC received 2 doses of neoadjuvant cemiplimab before surgery. And the results were remarkable. 55% of those patients after 2 doses achieved a pathologic complete response. No tumor within the resected specimen. And another around 20% had a major residual tumor regression, about less than 10% viable cells. Now, That's a single institution trial, but it essentially put neoadjuvant PD-1 therapy on the map for CSCC.
And those findings were later confirmed in the phase 2 study by Gross et al., published in the New England Journal of Medicine, where 50% of patients achieved a complete pathological response.
We started also seeing confirmation across multiple other agents. The NEO-SEEK study looked at perioperative cemiplimab and reported pathologic responses in over half of patients, while Amatore et al. At UPMC presented phase 2 data with pembrolizumab at ASCO in 2024, showing a 57% pathologic complete response rate and an additional partial response, about 8% of patients. Likewise, DV et al. In 2004 demonstrated promising activity of atezolizumab, further reinforcing that appears to be a class effect. This neoadjuvant effect is not just PD-1, it can also work in PD-L1 blocking agents and across all the various agents.
And now we have combination data from the Matisse trial published in Nature Medicine. That randomized study compared nivolumab alone to nivolumab plus low-dose ipilimumab before surgery. Both arms performed impressively, 55% pathologic response with nivo alone and 80% with the combination. And about 20% of patients declined surgery altogether after achieving a complete clinical remission, and most remained disease-free beyond 2 years.
It's really extraordinary, Dr. Miller. These responses tend to occur very early, within 6-8 weeks. Toxicity has been acceptable, and we'll dive into that a little bit. But the potential for functional preservation, it's really tremendous. For a parotid or a scalp tumor where surgery would mean facial nerve sacrifice or a large free flap reconstruction, or even in areas just that are complex in the corner of the eye involving the nose where the lesions may be smaller, but equally as disfiguring. Neoadjuvant immunotherapy can convert an otherwise morbid and difficult operation into something much more manageable.
Exactly. And the consistency across the studies, whether cemiplimab, pembrolizumab, atezolizumab, or nivo plus or minus ipi, is really striking, with pathological response rates hovering between 55 to 80% and durable disease control. And this isn't just research anymore. The latest NCCN guidelines formally acknowledges neoadjuvant PD-1 therapy as an option in select patients with borderline resectable, rapidly progressive, or very high-risk CSCC, especially when surgery alone would cause major functional or cosmetic loss. That endorsement really validates what we're seeing clinically.
Would you say that it has moved from investigational more to the integrated or standard care practice that you're considering?
Absolutely. But I think about the most common reason I am not writing a prescription for anti-PD-1 therapy in our CSCC patients. It is in this preoperative setting.
I agree as well. It's moved from investigational to integrated, and I think of it as almost a pseudo first line, or at least what we're reaching for to thinking about first. But we need to think about team-based planning when thinking about that approach, how to make that decision upfront, whether to start with systemic therapy instead of surgery, or when surgery is going to be incorporated, if at all. It's a huge cultural shift. It's a huge shift in terms of how we think about this disease and its treatment.
And it's a logical transition to our next topic, how adjuvant postoperative PD-1 therapy is building on this same success to reduce recurrence risk after surgery. So far, we've talked about the neoadjuvant setting, but let's shift gears to this adjuvant space. Patients who've already undergone surgery, plus or minus radiation, but remain at high risk for recurrence. This is where we've finally seen phase 3 data that are reshaping this field.
Yeah, the landmark study we're talking about here is CPOST, phase 3 trial that tested adjuvant cemiplimab compared to placebo after surgery and radiation for high-risk CSCC. Now, this was a very long trial, almost a decade-long trial to answer this question, and it was very well thought out. That high-risk portion deserves a little bit of clarification, because high risk can mean a lot of different things. But high risk in this scenario is really the worst of the worst locally advanced tumors. High risk defined as tumors that had extracapsular extension of nodal metastases, or when there was nodal metastases, there was multiple, 3 or more, or tumors that had in-transit disease, which we know gives us concern of more diffuse potential spread, as well as deep primaries going all the way down to the bone or involving perineural invasion of large named nerves, clinically significant nerves where you can see radiographic invasion of the tumor. And the results in those patients were practice changing, I would say, Dr. Miller.
Right. C-Post enrolled 415 patients and showed a 68% reduction in the risk of recurrence or death with cemiplimab compared to placebo alone. Hazard ratio 0.32. That's about as good as I've seen in the adjuvant space across diseases. Now, median follow-up was around 2 years, and a 24-month disease-free survival was 87% with cemiplimab versus 64% with placebo. That's an enormous difference for a disease where recurrence after surgery and radiation used to mean very limited options.
Now, Dr. Miller, you said this is as good as it gets. Maybe you can give a little color to our audience here and how they should think about that number, that hazard ratio as 0.32. Can you put that into context with the melanoma and the landscape of adjuvant therapy that's been approved for over a decade now?
Yeah, that's right. When we think about skin cancer and you think about the diseases where we are using postoperative systemic therapy, most of the time it's postoperative immunotherapy. Melanoma is that disease. Now, we do have some data, Merkel cell carcinoma in the postoperative setting, but nothing approved. So melanoma is where we're using single agent anti-PD-1, combination BRAF/MEK inhibition. And those studies have validated those use in melanoma were impressive. Hazard ratios that range between 0.4, 0.5, 0.6. So significant advantages for patients, but a hazard ratio of 0.32 really is a tremendous risk reduction.
And not only a tremendous risk reduction, but impressive that the benefit was consistent across subgroups of the patients enrolled in the trial, both nodal disease patients, non-nodal patients, those risk factors that we discussed, either the primary tumor or patients that had nodal disease, or whether the tumors were PD-L1 positive, PD-L1 negative. The toxicities were manageable, no new signals. Grade 3 or higher immune-related events was about 24% of patients treatment, and the treatment discontinuation in about 10%. So consistent with kind of what we think about from a immunotherapy class standpoint, as well as toxicity profile. And importantly, as I said, no new safety signals. It really reinforces the idea, the feasibility of using adjuvant PD-1 blockade.
And these data led to the FDA approval of cemiplimab as the first and only immunotherapy indicated for adjuvant treatment of high-risk CSCC following surgery and radiation. It's the first definitive advance we've seen in this disease setting.
What makes this especially interesting, the adjuvant landscape so interesting right now, that not all the data was uniformly positive. In fact, we had 2 trials running at the same time. The other trial, a large phase 3 trial, was Keynote 630. This tested pembrolizumab compared to placebo after radiation and surgery in high-risk CSCC, and it was stopped early for futility. And at interim analysis, there was no improvement in recurrence-free or overall survival. So now we have 2 phase 3 trials of adjuvant PD-1 therapy in CSCC, in high-risk CSCC after surgery and radiation, C-Post with cemiplimab, Keynote 630 with pembrolizumab, but with seemingly different outcomes, one positive, one negative. How do you make sense of this, Dr. Miller?
Well, I think this is where things do indeed get a bit nuanced. In our perspective on the Science editorial that we recently published in the Journal of Cutaneous Oncology, we emphasize that these aren't necessarily contradictory results, just different in meaningful ways. Right? The trials varied slightly in eligibility and timing, factors that can shape outcomes. And it's worth remembering that Keynote 630 has only been presented in abstract form so far, so not yet peer-reviewed. Therefore, many of the finer details are still emerging.
And that brings up some of those other key points, that these trials were not truly opposite. they're not opposite results necessarily. Even in the Keynote 630 trial, the hazard ratio still favored pembrolizumab around 0.76. It just didn't reach statistical significance. And when you look at the tolerability data, both studies trend in the same direction. PD-1 blockade reduces the risk of recurrence. The difference isn't about one drug working and another not. It's more about nuances in trial design, eligibility, and the baseline risk.
We actually did a Bayesian synthesis of the two trials using CPOS as the prior, Keynote 630 as the likelihood, to see what happens when you combine the evidence rather than treating it as a binary. The results showed a broadly consistent protective effect for PD-1 therapy across both data sets. And I think that's really the broader message, not to think of these as contradictory studies, but as complementary pieces of evidence pointing toward a benefit that's strongest in the highest risk, fully resected patients.
That's a great way to put it, David. I think that's really important for our listeners to key on and understand. It certainly is the way that I understand the two trials, that the quote unquote negative trial is actually a confirmational study from the standing of CPOS. The evidence supports adjuvant immunotherapy as a new standard. And the key is for select high-risk patients. It reminds us that not all patients will equally benefit. And by understanding the difference between the two trials, we can tease out how the timing, the specific risk factors, and the risk profile, as well as how a clinician and a multidisciplinary team can synthesize that data and make a decision, is key to getting it right and utilizing that information.
Such an important point. The bigger takeaway is that we finally have one positive, fully powered phase 3 trial with a survival signal. And the NCCN guidelines now reflect that. Right? They designate adjuvant cemiplimab as a category 1 preferred option for patients with high-risk disease after surgery and radiation.
And we can say now with confidence that adjuvant cemiplimab is the new standard of care for the right patient. And that's the key. Those with deep invasive primaries, those that go and invade the bone, those with perineural spread, not just any perineural, but clinical or radiographic nerves, the very large caliber, the nerve that when you resect a tumor, you can actually see the nerve, or patients with nodal involvement, and not just one node, but multiple nodes, or nodes that are more extensively involved such that the tumor is spreading outside the capsule. And in those patients, and what's key is that some of those risk factors you don't realize until after you have done surgery. And so after resection, when these patients are quote unquote upstage, or the surgeon and the team realize this is a much higher risk than the initially anticipated, the patients are going to be recommended for radiation. And now we can consider adjuvant cemiplimab therapy. It's what's exciting in how this is all coming together. We discussed earlier how we had really exciting evidence about the use of immunotherapy before surgery. Now we have confirmatory evidence that has an FDA approval for after surgery. Adjuvant can shrink tumors. Adjuvant can prevent recurrences. It really is quite remarkable. It's a remarkable shift in how we think about and how we manage this disease.
It absolutely is. It's important data to have. You know what? It's still, to me, like there's still some unanswered questions. We know in melanoma, for example, we're thinking we have data from S1801 and the DINA that show that preoperative immunotherapy is superior to postoperative immunotherapy. In squamous cell carcinoma, we don't have that data. We don't know. So now we have data that shows, again, we talked about the clinical benefit of preoperative therapy. We talked about the benefit of postoperative immunotherapy. And I think you really highlight and underscore it's a potential standard for the right patients. But we still need to figure out who that right patient is and how to employ preoperative and postoperative options.
And David, we're also early in this period, right? And so things are evolving. And I like to think that this gives us options for our patients. Patients who didn't have an option for neoadjuvant recognize they are very high risk. Well, now we can give adjuvant. It doesn't necessarily mean that that's the approach I'm taking when a patient walks in the door if we have that locally advanced tumor. But I think that understanding it as things evolve, as it has with melanoma, we've moved earlier, we're moving to smaller doses. It's about optimizing patient selection and managing toxicities. Would you say?
Yeah, I totally agree. And just to go back to this idea of like a standard of care, like it is a standard, it is a standard option. But I think it's also reasonable to have a detailed conversation, nuanced conversation with the patient that, yes, at this moment, we have a disease-free survival advantage. We don't have an overall survival advantage that's
Correct.
definitively established with using postoperative treatment. And we don't know, are we able to rescue or salvage patients that recur after surgery and radiation with a sort of neoadjuvant approach? So there's still a lot that we have to learn in this field and learn from our patients. But it is an important option, certainly, to have.
And with this disease, it's important whether you're 60 or 80. And I think that's what you're getting at as well, is that because of that continuum of presentation, standard can mean a different thing for a different patient.
Absolutely. It's about optimizing patient selection and managing toxicity. So it's going to bring us to our next section, biomarkers and risk stratification, the next piece of the puzzle. So listeners might be wondering, should I be ordering tests like PD-L1 or other biomarkers before starting these therapies?
Yeah, it's a logical question in a lot of other oncological solid tumors that certainly is considered, or looking at targeted mutations and profiles. In short, the answer is no. For cutaneous squamous cell carcinoma as a whole, we don't utilize biomarkers in CPOST and other data sets. The PD-L1 expression hasn't been predictive. That doesn't mean that there is a correlation, but it hasn't necessarily been predictive. There are tumors that are high or low levels that both have responded. Right now, we're really relying more on the clinical risk factors, the clinical presentation, the tumor size, the nodal involvement, the perineal invasion. Again, pulling from the clinical trial inclusion criteria as being which are the patients that were enrolled and had a benefit. Those are the ones that are driving decisions today.
Exactly. And while tumor mutational burden and novel biomarkers are exciting areas of research, they're not ready yet for routine practice in CSCC. I think the take home should be, don't wait on a biomarker result if the patient is clearly high risk.
Yeah, and as we celebrate the impact of immunotherapy in CSCC, we need to acknowledge its complexity. These are not benign treatments. And so even when toxicity isn't life-threatening, it can be profoundly life-altering. And so patient selection, multidisciplinary care are absolutely critical when initiating these therapies.
Right. Most papers headline the rates of grade 3 or higher immune-related adverse events, usually somewhere between 10 and 25% across the neoadjuvant and adjuvant trials. But that doesn't capture the full story. What we see in practice is that a much larger group of patients experience moderate, grade 2 toxicities, rashes, fatigue, diarrhea, thyroiditis that may not make the manuscript table up front, but still causes a major burden.
Absolutely. Those moderate events are often the ones that disrupt daily life. They can lead to steroid courses, treatment holds, repeat lab specialist visits. They may not require hospitalization, but they absolutely can impact the quality of life. And that's what I think is underappreciated, the time toxicity of these drugs, the clinic visits, the scans, the lab draws, the coordination that it takes to keep patients on track.
Completely agree. It's not just time toxicity, there's financial toxicity and emotional fatigue too. Managing chronic low-grade rash or diarrhea for months on end can wear patients down. And that's why these therapies shouldn't be given lightly. They need to be administered by clinicians and teams who are experienced and recognizing subtle early signs and know when to intervene.
And it's where multidisciplinary piece becomes essential. And also, I'll say for clinicians who may be thinking, I'm not going to utilize this, or this is not really within my wheelhouse, the early identification is key. So being aware of patients on it and keeping your antennas up to be able to get them to the multidisciplinary team is key as well. That multidisciplinary team can include dermatologists, oncologists, pulmonologists, gastroenterologists, cardiologists, everyone working from the same playbook. And many centers now use a standardized toxicity protocol, as well as patient education materials, some shared electronic alerts that can help ensure that issues aren't missed between visits. Dr. Miller, are you using any of those types of systems within your integrated center in Boston?
Absolutely. We have a pretty well established network now of specialists that we refer to. We have a specialized, protocolized inpatient service or severe immunotherapy complication service that really focuses on helping patients get through the treatment journey as successfully as possible. And we also have to be honest about patient selection, right? Not every patient benefits equally. And for some, the potential for immune related toxicity outweighs the advantage. I think the best outcomes come when we individualize therapy, as you mentioned before, factoring in comorbidities, patients' support systems, and how much follow up intensity a patient can realistically tolerate.
Yeah, PD-1 therapy is transformed outcomes when we think about just the disease state and think about patients that didn't have many options. It's been transformative, but it's also redefined what care means, what it means for them. And that's why I think I go back to understanding how that conversation or that decision is so different from a 50 and 60-year-old to an 80 or 90-year-old. We're not just managing the disease and the drug, we're managing the whole ongoing immune process, and that can be different at different stages of life. These treatments clearly save lives. They are, if you haven't had a chance to look at the images, it is remarkable, eye-opening resolutions of tumors, but they also require vigilance, experience, and respect of the human cost that comes with that success.
And as we've been saying, these advances they're incredibly meaningful, but they also demand thoughtful integration into real world practice. And that includes understanding how immunotherapy fits alongside other modalities and how we tailor care for patients with comorbidities or advanced age.
Exactly. And I know I've been hammering the point around age, but it's also around different types of treatment. So, one area that's gaining momentum is radiation immunotherapy sequencing. Radiation does not just control tumors, it can actually act as an immune primer. Moderate hypofractionated regimens, such as 8 gray or 3 fractions, appears to release a stronger immunogenic signal than conventional low dose schedules by inducing a type 1 interferon signaling and antigen release. Most of the data are from preclinical or translational, but the biological rationale is compelling. I can say from patients that we have treated in the metastatic setting that required radiation for bone mets, for potential impending fractures, just from a safety standpoint, we've sometimes seen some robust responses. But ultimately, we need more prospective trials to explore this optimal sequencing with PD-1 therapy.
Totally agree. And also, we're seeing parallel innovation in intralesional immunotherapy, which you mentioned earlier. A phase 1 trial of intralesional cemiplimab in recurrent resectable CSCC reported a pathological complete response rate of 76% across dose levels with no new safety signals. For frail or comorbid patients who can't tolerate systemic therapy, targeted intralesional delivery could achieve meaningful local control while potentially minimizing systemic toxicity.
Exactly. And importantly, phase 3 randomized trial of low dose intralesional cemiplimab versus primary surgery, specifically Mohs surgery, in early stage CSCC is now underway. We're very excited about this. The study is called CLEAR CSCC. It's a trial in progress, no results yet, but this intralesional approach, while it may be investigational, it's a very promising option that I certainly am watching closely for, thinking about my patients that are frail or comorbid or ones that just have had so many surgeries that now they've become fatigued or they've run out of areas that we can do surgery safely and easily, and ones that we are not able to necessarily give or have evidence to suggest utilizing systemic therapy in those earlier lower risk tumors. What that kind of dovetails us into is also the geriatric population. This represents the majority of our CSCC patients. The good news is that the efficacy appears to be preserved even in patients over 80, but the tolerability profile is different. Fatigue, thyroid dysfunction, dermatitis can have outsized effects and impacts on independence and quality of life. Tools like the G8 screening assessment or comprehensive geriatric evaluation can help us individualize treatment intensity.
True. And this is really about balance, right? Bring the benefits of immunotherapy to more patients while being honest about the trade-offs, whether it's combining radiation, using intralesional approaches, or treating older adults. The key is precision, matching the intervention to the patient's physiology, their goals, and their support system.
Well said. And progress for CSCC isn't just about new drugs. It's about responsible implementation. And that extends also to our implementation of how we utilize surgery, especially with an aging population, a skin cancer epidemic, the cost of that to the healthcare system. We need to leverage science while respect the lived realities of the patients that we are treating, as well as the whole health ecosystem.
So today we've covered a lot: neoadjuvant therapy, adjuvant cemiplimab, biomarkers, toxicity management, and emerging strategies like radiation immunotherapy and intralesional approaches. Dr. Patel, this field is moving fast.
Yeah, it's moving very fast, but the practical message is simple. Use what we have now for high-risk patients, stay proactive about toxicity, and be ready to integrate new strategies as data matures.
Well said. But before we sign off, let's look briefly at what's on the horizon. Where do you see the next breakthroughs coming from, Vishal?
Well, I think we're going to see big shifts, 3 big shifts over the next few years. First, personalized immunotherapy, moving away from a one-size-fits-all PD-1 blockade towards a risk-adapted or biomarker-informed strategies. We're learning that spatial immune profiling, circulating tumor DNA, ctDNA, and early on-treatment response signatures may help refine who truly benefits from prolonged therapy. Second, we're also likely to see next-generation immunomodulators entering into the picture, things like bispecific checkpoint antibodies, STING agonists, and oncolytic viral therapies that are designed specifically for skin cancers. Early trials are already showing us intriguing signals, but I'll also say third, and what I'm really excited about, and I'm going to push you to tell us a little bit about your research, Dr. Milner, is pushing the envelope a little bit forward in reducing dose frequency or even utilizing preventative approaches with immunotherapy that I think are really exciting.
Yeah, I think there are areas to innovate to continue to help patients. And we have, all of us, a collection of patients that have what people refer to as actinic neoplasia syndrome or field cancerization, where they have developed scores of keratinocyte carcinomas over their lifetime and are really suffering from treatment fatigue and also very high risk for regional and distant spread. And at the moment, we just have an inferior, suboptimal armamentarium for those patients. So can we use immunotherapy, some of these strategies that we've been talking about, to help those patients prevent future malignancies? So the immunopreventive strategy front is one that I find interesting and one that I'm really inspired to innovate on. And then, how many doses of therapy do these patients truly need is a question that hasn't been answered as well. And we look to the pharmacokinetics of some of these antibodies, some of the responses that you mentioned earlier about rapid responses. We need to better define how many doses of immunotherapy the patient actually needs in order to address some of those other toxicities that we talked about, the time toxicity, the financial toxicity. I think we need to find the right amount of treatment. We don't want to undertreat people, but we don't want to overtreat them either. So I think those are really important areas. And I'll add another area that I'm excited about. That's real-world integration as another frontier. How we implement all of this safely outside tertiary centers, right? Simplifying dosing schedules, building community-based toxicity monitoring, and creating pragmatic pathways for older patients or rural patients. It's going to be essential to expanding access.
Yeah, exactly. The science is moving quickly, but the real success will be measured by how broadly and equitably we deliver these advances. If we can make these therapies understood by all providers and patients, as well as accessible, affordable, and sustainable, well, then with this growing epidemic of skin cancer, will truly change and make a dent and improve the outcomes of patients with CSCC.
Thank you, Drs. Miller and Patel, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. Be sure to check back for more episodes on important oncology topics.